Welcome in to another episode of Ask the Doctor. Today, we are speaking with Dr. Angel Brown, a Cherokee lung and sleep specialist. Welcome in, Doctor. What's the difference between asthma and chronic obstructive pulmonary disease, or COPD?
The difference between asthma and COPD is reversibility. Asthma is considered a disease of airway narrowing or obstruction, but it is reversible, where COPD, it's considered to be, obviously chronic is in the name, a disease where there is no reversibility of the airflow obstruction.
How can you tell the difference between asthma and COPD?
Again, like I said, one disease is considered reversible, the other is considered to be a fixed disease. How providers or physicians can tell the difference is one, symptom triggers. Asthma has typical inciting factors that bring on symptoms, where COPD does not. We also do pulmonary function testing, which is readily available in most any pulmonary office. And that allows us to determine if you have asthma, because your pulmonary function testing will be normal, as opposed to COPD, where your pulmonary function testing has to be abnormal in order to have that disease.
Can asthma turn into COPD?
That's a good question. And no, it cannot. So COPD and asthma are two distinctive pulmonary diseases. So asthma cannot become COPD, COPD cannot be asthma.
How does asthma differ from COPD inflammation?
Excellent. So the difference in the inflammatory processes between asthma and COPD are related to cells. When it comes to asthma, since that is triggered by the host or patient response to inhaling something your lungs don't like, cells that are designed to recruit allergy fighters will go to the airway, nestle in, and cause inflammation. COPD, because it's triggered usually by bacterial infections, cells that are uniquely designed to treat bacterial infections, like white blood cells, will go to the airway into the lining and trigger inflammation that way. So inflammation is kind of the endpoint, but the way the airway gets inflamed in the two disease processes is different.
What is asthma-COPD overlap and how common is it?
So asthma-COPD overlap syndrome is an unfortunate disorder where a patient actually has both diseases coexisting. When you have asthma, it can be mild, intermediate, it can be moderate, it can be severe. When you have COPD, it can be mild, moderate, severe. If you have asthma and COPD, that entity is worse than having either of the two separate. You have all the symptoms of both diseases: shortness of breath, chest tightness, wheeze, and sometimes activity intolerance. And so you have to be treated fairly aggressive. The good news is the disease is rarely diagnosed, and it's only found in about 5% of people who are age 65 to 84. So it makes it rare, but it is a very serious disease, and it's much more severe than any asthma or COPD alone.
Is there any asthma-COPD link?
So there isn't a link per se, but like I mentioned, unfortunately, because it's an airways-based disease and they're both obstructive lung diseases, you will have a lot of common symptoms, but there isn't a link between the two, other than to say they're both triggered by something in your environment. Asthma is usually triggered by allergens such as pollen, dust. It could be pet dander. COPD, unfortunately, is caused by cigarette smoking, which makes it preventable, where asthma largely is not.
What are the treatment options for each?
So treatment options are really based on severity of symptoms and disease. So there are individuals with asthma who are walking around every day, all day, don't have symptoms, aren't on medication. It's considered mild. Individuals who have mild asthma can be on zero therapy, or they can be on an allergy medicine such as Montelukast, which essentially tells those cells that like to migrate into your airway to cause inflammation to not do that. If you have asthma that is active, meaning you have symptoms 3 times a week, such as wheezing, difficulty breathing, or if you have symptoms multiple times during the day, you should be on therapy, maintenance therapy, which is usually inhaled steroid. If the inhaled steroid isn't enough to have your symptoms wash away, you should be on an inhaler that has an inhaled steroid for inflammation and an inhaled bronchodilator, which cuts down on the tightness or the obstruction of the airway. Asthma that is very, very severe, you may even need to be on triple therapy, which is something that we reserve normally for COPD patients. When it comes to COPD, it comes also in different flavors. So if you have COPD diagnosed by lung function testing but have no symptoms, we monitor those patients. We encourage them to get their vaccines, influenza, pneumonia, because those infections can trigger a COPD flare. If you have COPD that's active, meaning that you're short of breath, walking to your car, walking up steps, or you're frequently getting hospitalized for infections, you should be on maintenance inhaled therapy to control your symptoms, and that would be triple therapy. And essentially, like I mentioned in asthma, a bronchodilator opens up the airways, inhaled steroid cuts down inflammation in the airway, and an additional medication that cuts down mucus in the airways, which is really a huge complaint for individuals that suffer with COPD. Now, the COPD asthma overlap, because it's a more severe disease, automatic, you don't step therapy up, you start those individuals off aggressively with triple therapy. You can also do testing to make sure there's no immune deficiency that needs to be treated as well. But the main thing is, if you have anyone with obstructive lung disease who is symptomatic, they should be on some type of inhaled therapy because that's the best management for that disease.
Do you have any concluding thoughts?
So I would say in conclusion, obstructive lung diseases can be very complicated, complex diseases. Because there's a lot of overlap with different diseases and with their symptoms, it's important to get the proper diagnosis and the proper evaluation. I would say any individual who is concerned that they may have an obstructive lung disease or someone they love has an obstructive lung disease, I would encourage you to talk with your primary care provider and seek referral to a pulmonologist, because the key to lung health is early diagnosis and early initiation of treatment.
This has been Ask the Doctor, presented by our friends at Northside Hospital Cherokee.